conjunctivitis has been fairly common, and a little bit of a runny nose or a sore throat on day one, followed by a complete absence of any symptoms subsequently, have been very, very common. And that's why people are not able to actually, though probably they are aware within themselves, they were not able to really say that we probably have COVID, and they didn't do the right thing of isolating themselves. The third thing which was seen in Mumbai and probably in many other parts of the state is of the country is that the infection was now obviously predominantly seen in the class which was not having that kind of a herd immunity or that kind of an antibody response previous to the previous wave. So in Mumbai, we had predominantly high risers and apartment blocks from where patients started coming, whereas the slums fairly remained untouched up until 2 weeks ago. Now the slums have started to basically get infected as well. But until 2 weeks ago, the infection was fairly commonly seen in these localities only. And the fourth, but not the least, is the mutant variant. And the mutant variant is causing a lot of concerns for us. So there is a double mutation and there is a triple mutation from Bengal, which has been talked about now. And this double mutation is found in almost as high as 60% of the samples which they did for genome study. We have only done around 0.1% of the samples for genome study. We haven't done a lot of samples for genome study, but I think whatever we have done, it has been grossly insufficient. I agree to it, but that is showing already 60% of the samples being involved. And that's a big worry because of two reasons. So those patients who are requiring hospitalization, the trend is that we are seeing a fair amount of population which is young. And that population which is young is between 30 and 50 years of age. I'm not seeing a lot of below 30 years of age who are critical or who are requiring high dependency or ICU, but a significant amount between 30 and 50 years of age are requiring this kind of a support in terms of intensive care. What I'm also seeing is that we have this biphasic illness, which I described just initially, that there is a symptom or two for a day or two, and then the symptom just disappears. And then when on day 6, day 7, day 8, fairly early on in the illness, we suddenly have a huge surge in their symptoms to the point that they come down very, very badly with the severe COVID. And before you know, they are in intensive care or in a hospital requiring high amount of oxygen or sometimes even support with NIV, HFNC, or even ventilator. It almost as if it looks like that the entire COVID bypassed the upper respiratory tract somehow and just directly attacked the lower respiratory tract. So, which is a big concern, because previously we were never seeing that. We were always seeing that the patients were, having a gradual worsening of the illness, and we could almost work out and have some time before they would actually deteriorate. Now we have patients walking in the emergency department with 30% saturation who had a symptom or two a week ago, and now suddenly we are finding them to go down. Another thing which is now seen in Mumbai, and I'm sure each one of you have noticed, is we were of the opinion that if we are vaccinated and we've completed 2 doses of vaccine and we are 2 weeks out of the second dose, then the antibody response which we have is fairly robust. And yes, it is indeed, if you do the anti-spike antibody, which the SRL does for us, is showing many of us carrying antibodies of greater than 250 to up to 2,500. And the cutoff value for that is 1. So at a 1 cutoff value, if you've got an antibody response ranging between 250 to 2,500, you would obviously want to believe that you are actually having a fair amount of immunity. And while you may be still susceptible to a one-odd infection, we are probably not going to get a moderate or a severe infection. And I can tell you, my friends, that I have now seen at least 6 or 7 patients across Mumbai and Maharashtra young doctors who have completed their vaccination. Of course, I have not got the data of their antibody response, but who've completed their vaccination, they're 2 or 3 weeks out of it, maybe some of them are even 1 month out of it, and have had severe disease and even death, which is what worries me, because this is what I brought up in the FMC, that if as a healthcare organization we were thinking that by vaccinating everybody we are going to be reasonably safe, I think the concept still is true more or less, but it is not a point to let your guard go down. And I think that's what we need to be basically worried about, that if I am vaccinated with 2 doses, and even though my spike protein antibody is good, you may still have a little immune escape, which may be seen with this, the mutant strain. Then you would probably have an immune escape seen in one of us as well. And we should not be putting our guard down. Somebody asked a question, which vaccine did these doctors take? Look, most of them have taken Covishield as medical professionals. Only few of them have actually opted out for Covaxin. So most of them is Covishield, but I don't think it's a matter of Covishield or Covaxin. We still need to be very, very clear that whatever vaccine we take up, it is not conferring us 100% guarantee that you will not have a severe disease. Last week we were referred a 33-year-old psychiatrist in one of the peripheral hospitals in western suburbs of Mumbai for an ECMO. And before our team could actually go and retrieve him on ECMO, he succumbed to it. So it is true that most of us will be protected from a severe disease, but not all of us will be protected from a severe disease. So it is mandatory that we all wear a double mask. I think that's what I'm talking about. This is my mask here. I'm wearing the N95 and I'm wearing a double mask on top of that. And if I'm not wearing a double mask, I don't think I'm protected. The first mask, the one on the top, is to be thrown off once we use it for a few hours or once we come out from a patient care area. And the N95 mask can be continued to be used, provided every time you go out, you put up another mask on top of that. And that mask may not be protecting you from probably from filtration of the virus or the viral particles, but it is certainly protecting the outside of your N95 mask, which you often tend to touch or grab hold of while you're just pulling the mask out. And I see a lot of them doing it. Only people who are regularly visiting inside the COVID area are actually knowing and are aware of how the mask should be removed. Most of the other people just grab out the outside of the mask and remove the mask, just pull it out of their head. And while doing so, they go very close to their eyes. And while doing so, they might be even rubbing their eyelids or something and might be causing a breach in the infection control protocol amongst themselves. So this is the second thing which I wanted to talk about. The third thing which I want to talk about is the treatment protocol. So what has changed? What is it new that we should be doing? And what is basically now that we have learned in the last 12 months that we should not be doing? And this is where I have got a very reasonable protocol for our Mulund unit and for Raheja as well, because I'm visiting there now. But I'm just going to share what we do and what is the current evidence for. So let's start off with the hot topic, which is remdesivir. So remdesivir, we all know in number of trials which has been done, is not a magic bullet. It has not shown to improve mortality whatsoever in any of the trials done. However, because it sort of has got a good evidence to show that it does stop the viral replication, it has been used in moderate or patients who are moderate progressing on to severe disease. And it should be used between the first 2 to 10 days of onset of symptoms, not from the 10 days of detecting positive, from the onset of symptoms. It should not be used in asymptomatic or mild patients, and it should not be used in those patients who are very, very critical, perhaps on a ventilator with multi-organ dysfunction. So the best evidence for it is to be used in moderate to progressing to severe. So a very good way to categorize would be that if you require oxygen, then you use remdesivir. If you don't require oxygen, you probably don't use remdesivir. If you require ventilator, you're too late for remdesivir, is what my ballpark assessment of the situation is. The second drug, which has been highly talked about, is tocilizumab or itolizumab or bevacizumab. All of these are monoclonal antibodies, and these monoclonal antibodies have been used for the so-called cytokine storm. In our unit in Mulund, we have not used a monoclonal antibody of any nature since the month of September last year. I think August was the month when we used a few, and we stopped using that. For a few reasons, we analyzed our own data and found that our mortality was of probably worsening when we were using tocilizumab because of the secondary infection which these people were having. And secondly, number of trials, including we were a part of one of the trials from Mulund, which was a multi-center randomized control trial, and we found that there was no benefit in using tocilizumab. So the question comes, what do you do for a cytokine storm? So for cytokine storm, we still use low-dose steroids, and we may not go beyond 2 milligrams per kilogram maximum. It's usually 1 to 1.5 milligram per kilogram. 40 TDS is what we give the most. But we adhere to the standard intensive care protocol. And that standard intensive care protocol is we look at the ARDS-NET protocol and we follow it. Prone ventilation to the T. ABG looking at PF ratio. The PF ratio drops down below 100 despite best of our ability with NIV or HFNC. We would then think of ventilating them electively, ventilate them, prone them electively. And we found that it actually works in our favor. Most of our patients, the so-called cytokine storm is fairly controlled if you give them good supportive care. If you start using these monoclonal antibodies as a substitute for good intensive care or ventilation, that's when the problem starts happening. Most of the hospitals outside in the outskirts of Mumbai are doing that. They would flog on a patient on 100% FiO2, giving tocilizumab after tocilizumab, baricitinib, bevacizumab, or sometimes high-dose steroids, and actually not be able to do what is right for the patient, which is intubate them and keep them sedated and prone them. So that's my sincere plea that there's no substitution for good intensive care, what we should be doing. Then there is obviously the steroids. I've touched upon that you need to give steroids once the hypoxia sets in. You may choose to give steroids if there's a rapid rise in some of the cytokines. Special attention to CRP is what I would look at here. If CRP is rapidly rising and the patient is having fever, looks like the patient is going to go down as a clinical examination, or if on a walk test, the patient drops down the saturation by 3% or more, you can give them preemptive steroids. That's probably the only way only little evidence which you have for steroids preemptively. Otherwise, all the evidence for steroids is when you have hypoxia. So don't miss out giving steroids when you have hypoxia. I don't think anybody is doing that. I think most of us are fairly vigilant and are using steroids quite extensively when there is hypoxia. But that little trick may just help you if you find it that their CRP is rising every day by 20, 30 points, and they seem to have a fever, or on the walk test, they seem to be desaturating just that little bit more than what they were doing before. Those would be the times when I would use steroids. Apart from that, we did a trial on a drug called as thymosin alpha, and I have been using it in critically ill patients now. Thymosin alpha is a thymus gland precursor. The evidence for that is very, very low and anecdotal. We are the only trial which has been done up until now in India, and even that was just a pilot study of 15 patients. So I would not place it as a high and not recommend it as a evidence to be used. But if you have a patient who has got a lymphocyte count less than 10%, and I'm very often seeing patients having lymphocyte counts of 2%, 3%, 4%, then I'm giving this drug as an adjuvant therapy to the standard of care. And I'm finding that once their lymphocyte count picks up, we actually see a gradual improvement in their inflammatory markers as well as clinical condition. So that's one little thing which I'm doing differently. But if you ask me and challenge me that should you be using it for other patients, I would probably say the evidence does not support it to be included in the guideline. That's why it's not included in the guideline right now. But other things like baricitinib, bevacizumab, ulinastatin, infliximab, I am actually not using any of them. Now, let's answer some of the questions which were said. Unless you have a specific question to talk.
No, Rahul, I think I would actually be very selfish, ask our critical care chief Padma Kumar to start the question, and then Dr. Pooja will ask questions or share, then Dr. Vivek Padigal, then our physicians Sheila and Sudha, because they are the ones who are handling them. PK, please go first.
Good evening, Dr. Rahul. Thank you for your talk. I think I might have sent a message sometime back about the tocilizumab, basically because people have started talking too much about tocilizumab.
Correct.
And in our experience also, last wave, actually we have used only very few, 2-3 patients. That's it. And we immediately realized that the outcome was not great. So actually we haven't ever used it extensively at all. So that's why I thought maybe since you have done it much more extensively, I get an opinion from you. Second thing is that I just wanted to know, when did you generally start the antifibrotics? Because we see a lot of patients after their second week, their complaints.
So we are starting it in the third week. Third week we are starting it. If they still require, and if you start seeing traction bronchiectasis on the CT scan, or we see that the compliance is extremely poor, third week usually I start with antifibrotics.
And one more interesting thing, what we noticed is that this wave actually we have seen people who has got a much more higher levels of ferritin compared to what we used to see in the first wave. Are you also seeing that, or is it just a coincidence?
No, it is not a coincidence. Ferritin is high, but none of them have actually shown any HLH as such. So that's why
it was interesting, because we have not seen it the last time.
Correct.
Maybe it's something a gene variant or something in the virus, most likely. Maybe.
Thank you, PK. Vivek, you have raised your hand.
It can wait if I'm getting my turn, but if I... hi, Vivek Patikal here. I'm the pulmonologist. Do you have any opinion on baricitinib with the remdesivir? Have you had to try it at all?
So I have not. I've tried it in a few patients, not in Mulund, but there are some patients who I sort of VIPs who consult us, and they've already put them on baricitinib. The problem which I have with baricitinib is that the trial which was done actually excluded steroids. So they use only baricitinib with remdesivir, and steroid is a standard of care. To exclude steroid and instead, I don't have the confidence still. I am still a little bit of a conservative guy that I would think that baricitinib should be used. And then if you use baricitinib plus steroids, then it is probably you're immunosuppressing them too much. Already we are seeing a tsunami of mucormycosis. Every single day we have one patient with mucormycosis who is referred to us from periphery. But because we've been very, very conservative with immunosuppression, touch wood, in all of these 8,000 patients that we've seen, we've only got one patient who had mucormycosis, and that was way back in the first wave. We haven't seen anybody yet with mucormycosis from our unit who has come to us.
Our experience has been similar. The only mucor we got is from outside. We've not had any internally as well. So I think it is a very valid point about immunosuppressing these patients. Do you think prolonged steroids is a risk factor for mucormycosis as well, or do you think it's only the biologicals?
No, I think prolonged steroids on a background of diabetes or diabetes, which basically the blood sugar alteration which happens because of the COVID-19, along with something else, actually worsens it. So whether you use baricitinib or tocilizumab or the biologics, as you said, I think those are the patients who are at high risk. Almost all patients have received tocilizumab or itolizumab this time around, which I'm seeing. Almost all of them. Alternatively, there are a couple of patients who received high dose steroids, 500 milligrams of pulse for 3 days, 250 of pulse for 3 days.
Okay, so the duration is the other question. We have been For the very severe patients, we have been giving steroids for a prolonged period of time, but we are getting more cognizant about coming down on them, especially after day 14. So day 14, we start coming down the steroids quite a bit, quite fast.
Sorry, doctor, your voice is not very clear.
Sorry,
Sir.
can you
All
hear me
right.
now?
Vivek, there are other people, and we have to let Rahul go at 4:40.
Okay,
So
sorry.
if there is time, I'll call you back, please.
Okay.
Vivek Javli, please.
Hi, Rahul. Good afternoon.
Hi, sir.
My question was between the second mask over the N95 versus a face shield, what will you vote for?
So is this a question you are asking for operation or just during OPD?
Especially the OPD doctors.
Yeah. So I would probably use both. Just don't know who is walking in your room right now. So a face mask, you could wear an eye shield. For those who have prescription glasses, you could wear your goggles. Those who don't have prescription glasses, you could wear those transparent goggles. Or if you have prescription glasses, then you wear a face shield.
Okay,
On
thank
top
you.
of the double mask, sir.
Okay.
Okay. Thank you. Dr. Pooja, you have any questions or comments? She is our critical care specialist. Pooja, unmute yourself if you are talking. Okay, Dr. Jayaprakash has raised his hands. Are you there?
Yes, sir. What is the ecosprin and low molecular weight heparin?
Sorry, what is the
Role of ecosprin and low molecular weight heparin? How long, when to start, and how long to be?
very good question. I think patients who are on outpatients department, who are mildly or asymptomatic patients who we are treating, probably have got no reason to be anticoagulated, even if the D dimer is a little bit high. I think we are overdoing anticoagulation at just D dimer numbers. But patients who are in the hospital require to be given a DVT prophylaxis dose of low molecular weight heparin, and that should be then upped to a therapeutic dose or twice BD dose if we have a very large surge in the D dimer associated with a clinical deterioration as well. Otherwise, all the three societies, the American Society, the Chest Society, and the ITSA, Infectious Disease Society, actually came out with a good slide. I will share that slide with Murli sir now. I have it on my WhatsApp, and that's a very good summation of what we should be doing and what we should not be doing in terms
Okay.
of.
I will share it with whoever wants on our hospital group. I will share it on the Apex and other groups. Okay, Dr.
Yeah.
Sheila, you have any question?
Good evening, Rahul.
Good evening.
It was a very good talk, but we are not intensive physicians, so we want many number of people not reaching you guys. Is there any change in the protocol and how we could really treat the early intervention that we could do to help people not reach the serious stage?
Yes.
Any drugs or any?
Yeah, the early intervention, the trial which has come out in Lancet just now is talking about inhaled budesonide, which can be used as a 400 micrograms inhalation twice a day for patients who are mildly symptomatic. And they found that the number needed to treat was 8. Most of them did not have any hospitalization once they were put on that. And the second thing was obviously that the recovery was also shown to be early. The second thing which I'm doing now regularly is that even from day one, if they are being consulted at home, I request them to lie down prone in their houses as well. And basically, we are now using favipiravir. I know the evidence for favipiravir is limited to Dr. Zari Rudwadia study only in India, and there is no other study. But it is still better than ivermectin. It is better than ivermectin. Those who are asymptomatic, we don't give any either ivermectin or favipiravir. But apart from that, favipiravir is the drug which we use for mildly symptomatic patients and prone position.
I have also found good results with favipiravir.
Sorry.
I have also found results good with favipiravir, so we can continue to use the favipiravir. Yes.
Yes. I think
Thank you.
to monitor liver function test and uric acid, and most people seem to tolerate it quite well.
Okay. Sudha Menon, do you have any questions?
Yeah. Hi, Dr. Rahul. Any role for colchicine? There have been anecdotal evidence on colchicine. Do you use it at all?
All of these have got, again, poor evidence. Poor evidence. Now,
I'm going to mute all except Rahul. Please, Rahul, unmute yourself. Okay, and Manish Mattu.
Yes, hi, Dr. Rahul. I have a question regarding the severity of cases in the moderate cases. What percentage of cases have you seen turning severe? And I'm asking you purely from a capacity building standpoint, that how many beds should we keep reserved for such cases?
So I think the patients who are getting admitted to the hospital, almost 20% of the patients are requiring intensive care, or maybe even more, 25%. And every single day, I'm shifting a few patients from the wards into ICU. And we are now managing more sicker patients in the wards than what we were doing in the first wave. So right now, I've got many patients in the wards who in the first wave, I would have probably taken them into high dependency area or in ICU. And I'm trying to add another 10 beds of ICU, which will make us almost a 45-bedded unit. We have got 35 beds right now functioning.
Got it. Thank you so much. All the best.
Rahul, there have been a lot of questions about taking Covaxin in addition to Covishield. Dr. Naha Mohan Puttaswamy Deva want to know it. What is your take on that?
So there is no evidence for that right now. I would say that we should take whatever vaccine we have taken. We should review that in 6 months' time in terms of antibodies, and probably try and go for mRNA vaccine in 6 months' time, which will be available, Pfizer or Moderna.
Okay. And Dr. Anu Sridhar?
Good afternoon, Dr. Rahul. I just wanted to know, is there any evidence world over that people who have finished their doses of vaccination and have been infected with COVID, and what is the antibody level in them? If not in India, wherever else?
Oh, many of them have got, madam, with even high antibody levels, many of them have come positive with COVID. That's not new at all. What is problematic is that now I'm seeing even severe disease in them. It's only few of them, but some of them are coming down with severe disease as well.
So severe disease even with high antibody level, is it?
Yes.
Okay. Dr. Ashok Kumar?
But they are there.
Yes. Good afternoon, Dr. Rahul. I wanted to know any experience or your opinion about the nitrous oxide inhalation?
Nitrous oxide inhalation has not shown to have any mortality benefit in the previous ARDSNet trials done. In the current scenario, it can be used as a salvage therapy, sir. We have not used it as a salvage therapy. We believe that you prone them for a number of days, and you would probably have a better outcome rather than giving nitrous oxide. But yes, that's one more study where there are 2 studies of nitric oxide which are going on right now, and it remains to be seen whether it actually improves the outcome or not.
Anita Arora?
Good afternoon. Thank you, Dr. Murli, and thanks, Dr. Rahul. I mean, it's such a pleasure listening to you. So I just have this question, which I've anyway posted here, that would you be able to share some guidelines for home care for COVID positive patients? And would that be age dependent or other factor dependent? That's one, that's home care. And what would be the indications for admission, or what is it that are the early warning signs for an admission? And would that also be age dependent or any other factor dependent?
Right now, there is a lot of confusion about who should be at home and who should get into a hospital. And many of us are using CT scan as a surrogate marker. But I think it should be the clinical parameters which we should be looking at. So the first and foremost, any patient who is asymptomatic can be cared at home. Any patient who is mildly symptomatic means he's got fever, He may not have a lot of cough, a bit of cough, and he's got a normal saturation at rest as well as after 6 minutes of walk test. Then you also look at the age and comorbidities, and patients who may have immunosuppression as a comorbidity because of whatever, maybe they are a transplant candidate, they have had a transplant done, or they are HIV with a very poor CD4 count, or they are on solid immunosuppression for some rheumatic disease. Those are the ones we need to keep a special eye on, and those are the ones where the red flag should be raised up. Every patient, no matter how old or young, should undergo a 6-minute walk test every day in the house twice a day, morning and evening. And if there is a drop in saturation greater than 3% or absolute drop below 93%, they should essentially be presenting to the hospital for admission. Fourth one is any rise in the fever after 4th or 5th day, which is significant. Significant means more than 100.5 degrees Fahrenheit or more than 38.5 degrees centigrade, whichever you measure. That's a warning sign that actually we are now having a biphasic fever coming in, and the patient may be heading in for a trouble. Those are the patients which we can get them for a admission. Obviously, patients who have got a very bad CT scan score, which is basically more than 12 or 13, and even if they look clinically okay at that time, trust me, when we do a walk test on them, they are desaturating. So these are some of the red flags we have to look. There is something called the fragility index. Fragility index is for patients who are old and fragile. The NHS uses it. I can pass that fragility index. You can even do a quick web search about fragility index for old patients. Anybody who has got a fragility index of greater than 3 should probably be in the hospital, because they are too fragile to be in at home. And anybody who has got a fragility index of greater than 5, in fact, NHS, in some of my friends are saying that NHS is actually saying that you probably treat yourself at home, because the outcomes are extremely poor with that kind of illness. So we are not obviously going to do that, but at least fragility index of 3 and above should be in the hospital care, not at home care.
Sure. Dr. Manisha Singh.
Thank you so much.
Dr. Al, this is Dr. Rajpal, cardiologist here at Fortis Banagata Road. I don't know if anybody has spoken about this. We have noticed that there is less of cardiac manifestations in this second surge of COVID. We saw a lot of acute myocardial infarctions, acute coronary syndromes. I review echoes on COVID patients almost on a daily basis. I don't see that much of myocarditis either. Is this something that you've seen across in Bombay as well?
Yeah, more or less, sir. We do have a odd myocarditis or a myocardial infarction coming positive, but I agree with you. In general, it has the incidence has been much lower than what we saw in the first wave, and given the fact that second wave has got 3 times more the number of patients we are actually admitting as well, the numbers are low. Yes, the numbers are low, but as in Bannerghatta or Mulund, because we are tertiary care, we would probably see a little bit higher because patients would be referred to us. But in general population, I don't see that much of myocarditis or myocardial infarction or arrhythmias to be very common there.
Thank you. Last question goes to Chaitanya. I would have asked the question, but I can't even read those drugs. So Chaitanya, you only say that.
Hi, sir. Dr. Chaitanya, pulmonologist. Hi. So in the third week, you said you are for severe COVID patients, you are starting on these antifibrotics. Which one do you prefer, pirfenidone or nintedanib in your clinical experience?
Pirfenidone is what we start off with, but there is a growing school of thought that nintedanib can be used as well. And the nintedanib actually has got more VEGF suppression, so there is a problem with the bleeding if you are going to use anticoagulation as well with that. Whereas pirfenidone, already obviously the liver function test needs to be looked at. So, but per personal choice, we start with pirfenidone, and then I involve a pulmonologist after 3 weeks or so that we have a joint care going on for these patients. And most of them, I find that if we go on a full dose of pirfenidone, up to 400 to 600 milligrams 3 times a day, they tend to do well. I've been speaking with Zarir Udwadia as well on this because we are on the task force together. And he is also been prescribing pirfenidone unless he's changed practice recently. But that's what our guidelines say as well.
The really last question, Dr. Manish Joshi.
Yeah, and with the COVID surgical emergencies, we are worried about the smoke evacuation and aerosol generation procedures. But surgically, I still feel that laparoscopy is a simpler and faster procedure than doing open surgeries and then having wound management issues within a COVID positive patient with steroids, possibly as a treatment option. So, what has been the input from your end? What is the experience with surgical emergency?
I think we've gone past that point, sir. So most of us would recommend that whichever procedure the surgeon feels comfortable with, we should do that. There is very minuscule chance that if you have a breach in your personal protective equipment, only then you would have some infection coming in from the smoke and the evacuation of that smoke and stuff, the scavenging of that smoke and stuff. So I think whatever is comfortable, and laparoscopy certainly seems to be the most comfortable thing to do. We've had all sorts of surgeries done, neurosurgery done, cardiac surgery done. We've had obviously abdominal perforative peritonitis and stuff done. So, but yeah, I think it's your choice now to sort of decide which surgery to do. Easier to do laparoscopically and get away with a smaller wound and easy management of the patient.
Sure, Rahul, this is a question from our ID. How can I refuse him? After this, you can even run away. I don't mind. But Prutu, please be brief.
Hello, good evening, sir. Thank you for an excellent brief talk about COVID. I just wanted to know the.
Hello?
Second
Prutu,
wave,
you're not audible.
do you feel the ignorance of people following social norms, or actually is it the B1171 which is spreading because we are not doing enough serotyping for all people?
A good question. I think it is a combination of two. I really feel that we got it completely wrong. All of us, including our politicians, doctors who were in position to influence, all of us sent a wrong message out to people. And laymen being laymen, they are not going to basically listen anyways. And when the wrong message was sent, that people are patting and congratulating each other that how well we have done. And suddenly when these large weddings were being organized, people were not wearing masks. The government at the same time actually declined their surveillance, decreased to the point that they were not bothered about it, sent out a very wrong message about COVID appropriate behavior, one. And we always knew that there was going to be a mutation. Just that this mutation was so bad is what we were not prepared for. And I think that's a combination of what is happening essentially.
All right. I think we have got a lot of information in a short time. Most of your informations have not been extraordinarily encouraging. So will you answer this last question from Naga, who is asking what is going to happen in the next 4 weeks? Some good news?
I think in the next 4 weeks, so the good news about this pandemic second wave is that it will probably go away as quickly as it has come.
Oh, thank God.
And most of us believe that, and I've been speaking this with ICMR guys, and I'm sure you guys have your sources as well. It looks like it always plays a, and I'm speaking with our colleagues from UK and US. It looks like it's a 120-day cycle. So it started off in first week of February in Mumbai and Maharashtra. March, April, we are on April 20th now, which is around 60-70 days down the track. And I'm already seeing that Mumbai has plateaued. So has some of the other cities which started off in the first or second week of February, like Amravati and Vidarbha and stuff. And I think in a 10 days time, we should start seeing Mumbai's numbers coming down. But the bad news about the second wave is that when the second wave comes, the third wave is already staring at you. And Anu Sridhar is asking the same thing. When is the third wave expected? I think third wave is expected in another 100 days when the numbers go down. That's why it's going to be 100 to 120 days. When the numbers go down, you will expect the third wave to come. And only way we can sort of escape from the third wave is if we are able to vaccinate maximum amount of population within the next 4 months, which are left. And we need to vaccinate probably 1 crore people per day. We able to get that done in next 100 days or 120 days. And if we're not able to get that done, third wave will definitely come. It will come 100%. We need to be better prepared in terms of our infrastructure. We need to be better prepared in terms of our oxygen availability. In fact, on the FMC, I've put up today that we should prepare for having air concentrators in the hospital installed. The Maharashtra government task force has actually recommended that every hospital which is above 200 beds should opt extra air oxygen concentrator units to be put up along with their liquid oxygen plant or whatever they are using, so that they are not dependent on supply and they're able to generate some oxygen within their own campus, which is probably going to be a life-saving thing for the third wave. The third wave again is worse than the first wave, but probably better than the second wave is what the history tells us. But nobody knows how we are going to behave as a country. And if we are able to vaccinate everybody, the government should not let their guard go down this time around. The epidemiologists are all saying that when the wave goes down, step up your surveillance, increase your testing, concentrate your testing on where the cases have come positive from. For example, if the Mulund is testing positive, you micro-contain the entire Mulund area. Don't allow anybody to step out unless they are healthcare workers or they are emergency workers. Test everybody in that area. So if Mumbai is doing 50,000 tests today, maybe 25,000 tests can be done. And everybody, micro geographic containment, aggressive testing and tracing is what we need to do. Of course, zero tolerance for lack of COVID appropriate behavior. I am not a lawmaker, but Murli sir, if a law is to be made, cancel their Aadhaar card for 3 months. Do something which will actually hurt them so that they know that, I mean, 5,000 rupees fine or 10,000 rupees fine, only few of them will be able to pay. But some of them would just say we don't have money and they would get away because there is no way you can sort of extort money out of them. But if you do something which will really hurt them, I think that's when they will listen to it. Otherwise, they are not going to listen to it.
Thank you, Rahul. I think you are the man in the news. You must tell this. Maybe you will get to meet the Prime Minister. You should tell him about this seriousness. We are really, really proud of you. You're doing a great job. And I really wish God gives you good health. Take care of yourself. Thank you very much. Ladies and gentlemen, let's thank Rahul. Thank you.
Thank you very much.
Thank you very much, Dr. Rahul.
Thank you so much, Dr. Rahul. Thank you.
Bye.
Thank you.
Bye.
Bye, everyone.
Thank you.